pattern, which you can see here, which is, I think, very intriguing. The central scan patterns are usually high resolution, up to 10 micrometers per pixel, and you can really evaluate quantitative parameters. You can account for CNV, and these are used really to look at the center of the image. When you have wide field images, you have a wider field of view, and of course, because you scan a wider area of the retina, the resolution is not so high and can be up to 18 micrometers. You can see some of these images right down here. The intriguing thing in these wide field images is you can do wide field montage images. So by performing 5 12 by 12 scans, the device will montage it together, and you really get then a wide field of view up to 100 to 110 degrees of the retina. Or another possibility is to do 2 15 by 9 scans, and that's also automatically merged by the device, and you get a wide field of view, similar as a fluorescein angiography. I previously talked about the projection artifacts. So when you look at the deep capillary plexus, you always have to account for these projection artifacts. You may think, okay, I know that I will see the vessels from above, so who cares about projection artifacts? But it really helps you to differentiate the lesions and to quantify changes in the deep capillary plexus. For example, when you look at this image here, it's a slab of the outer retina and choroid capillaries. You may think, is there a CNV, is there no CNV? And when you do the projection artifact removal, you see that it looks completely different, and you can definitely see that there is no CNV lesion there. So projection artifact removal really helps us improve the visualization of CNV, and it allows the accurate evaluation of vessel density of the deep capillary plexus, and also for CNV, because also in CNV you will have projection artifact removal, and the CNV lesion which will look larger and the density will be higher before you do the projection artifact removal. And you also have to be aware where the projection artifact removal was used in the study you're reading, because the density rates may differ up to 50%. So the previous study, which were published on vessel density in the deep capillary plexus, always showed a vessel density about 48–50%, and now we know that the vessel density is about 25 to 30%. And of course, if you see the vessel from above, you might cover the extravascular changes in the deeper layers. So we use the central scans also to do quantitative assessment of the OCT images, and two of the main parameters to evaluate here is the vessel density, which evaluates the total length of the perfused vasculature, and the perfusion density, the total area of the perfused vasculature. However, you have to be aware that unfortunately these terms are not homogeneously used. So when you hear vessel density, you can't be sure that you're talking about the total length of the perfused vasculature, and you always have to go back and see what the definition was. And these parameters are very intriguing because they very nicely correlate with the severity of diabetic retinopathy, with ischemia in vasculitis, and also ischemia in retinal vein occlusion. But we still have to figure out what really impact these parameters have on the long run and long term. This is just one representative example. And as you can recall the pictures I showed you before from the 7 different images, you can assume that these vessel densities and these parameters really vary among the devices. We really have to cope with these problems, because now on there are multi-center trials coming, and we have OCT-A as exploratory outcome parameter, and we really don't know what to do with the data because they vary so much among the devices. Another quantitative parameter to evaluate is the foveal avascular zone in terms of the size, raw length, and circularity. And again here, due to the fact that you have different segmentation lines, these metrics may differ among the devices. Another quantitative parameter which is often evaluated is the fractal dimension. It usually shows you the degree of complexity of biological structures, and it's usually decreased in diseased eyes. And further quantitative parameters, you can evaluate with OCT the area of non-perfusion, the CNV area. There are various variables you can evaluate. So now I talked that there is a big difference among the devices. What about the reproducibility? So when I scan a patient and I scan it on another day, how reproducible are these data? So actually in terms of their foveal avascular zone metrics, the reproducibility is really high. Also, in terms of the vessel density of the superficial capillary plexus, the reproducibility is very good. The reproducibility is a little bit lower in terms of the vessel density of the deep capillary plexus. I apologize, I don't have a Mac, and my presentation looked a little bit different when I prepared it, yeah. All right, but you can also do quantitative assessments of the wide field images. And interestingly and very intriguingly, these parameters are very reproducible in terms of the average vessel length, the elaconarity, and the total number of junctions. However, no matter how good your image quality is, and if you have a signal strength from 7 or above, and you have no imaging artifacts, no motion artifacts, you still have to consider cataract, because your measurement, your quantitative measurement, will be biased by cataract and will be falsely low, even if the image quality is perfect. You just have to be aware of that and make sure, or just at least have it in mind when you look at the images and when you evaluate them. So in terms of their quantitative measurements, we can say that the inter-device comparison of the quantitative parameters may be quite challenging, at least right now, although some studies have reported good inter-device agreement. And the reproducibility of the measurements depends, among others, on the evaluated parameters and on the image quality. And as I still have a little bit of time, I want to go into detail a little bit on wide field OCT-A images, because I think it's a very intriguing modality. And for example, in all vascular retinal diseases, it's a nice way to depict lesion. For example, in diabetic retinopathy, OCT-A, wide field OCT-A, was shown to be as good as fluorescein angiography, and definitely much better than the gold standard of seven field images and wide field color fundus images. For the detection of neovascularization, it's also very useful, because sometimes on FA you may have a hyperfluorescent lesion and you're not sure, is it an ERMA, is it already a neovascularization? It won't pop up like a neovascularization itself. And if you do then the OCT-A, it can be identified as a neovascularization, or you say, okay, there is nothing, but you can definitely see whether there is something here or not. Okay. And it's definitely better than the ultra-wide field color fundus imaging in detecting neovascularization on the disc and elsewhere. It's also very intriguing for the evaluation of uveitis patients, for example, in birdshot. You can follow the disease progression. This was a patient just recently diagnosed with birdshot. You see the choroidal lesions here, but you see that the choroid capillaris is still not involved, and so you can follow the patient. You can also follow treatment response, for example, in VKH. You see all these granulomatous lesion blocking here. 10 days after glucocorticoid E treatments and 2 months of glucocorticoid E treatments, the lesions are completely gone. So I think, in the end, OCT is a new valuable image modality that allows non-invasive high-resolution display of individual retinal layers. However, we have to cope with different segmentation alignments and algorithms, and of course there's an inconsistent nomenclature, and we have a limited comparability in terms of the quantitative measurements. Thank you very much.